either let blood coagulate and you're left with the hematocrit plus serum, or you can spin it and where the clotting factors are still in the liquids, and you have the hematocrit plus plasma. In tubes, you'll learn in tubes where you do blood draws, if there's nothing in the tube, the blood will coagulate. But a lot of the tubes have something in them to make the blood not coagulate. And that can be either EDTA, which binds all the calcium. You know, calcium is required for blood clotting. Or the tube can be filled with heparin, which, as you know, prevents blood clotting. So, anyway, the thing you should appreciate is that the hematocrit is roughly 3 times the hemoglobin. So if your hemoglobin is 15, you can expect your hematocrit is 45. That would not be the case in the macrocytic or microcytic cells that I drew on the board. That's when you will find aberrancies there. You have to appreciate when you order blood, most of the time you will never order whole blood. It will be a component of blood based on that specific need. For example, if you're bleeding out, you only need packed red cells. You only need the oxygen carrying capacity. You don't need the plasma. So you get packed red cells. However, a unit of packed cells, a unit of whole blood, will raise the hematocrit 3 points, which is the same thing as raising the hemoglobin about a point. Right? Pretty simple. Where's hemoglobin? Oh, okay. RBC indices. If you're going to diagnose anemia, this is where it's going to be, right here. The hemoglobin will tell you that anemia is there. The indices, it will tell you what type of anemia or what category anemia you're dealing with. MCV is the mean corpuscular hemoglobin. Mean corpuscular volume. It's the average size of RBCs. You can see that it's done by just dividing the hematocrit by the RBC count. It'll give you the average size. Factor deficiency anemias. And there are 3 different types of anemia, 3 different categories. Production deficiency, factor deficiency, and depletion deficiency. Production deficiency, you're not making enough of them. Bone marrow suppression would be an example. Factor deficiency is you're not making enough of them because of something that's missing, like iron. And depletion deficiency would be you're losing them too fast, would be that gunshot wound to the abdomen, or the sickle cell disease, or some other type of hemolytic process.
So, like with thalassemia, that has a genetic connection, so how would you rule that out, or
Thalassemia is a wonderful disease. Most of the time, people have it, don't know it. It's characterized by hyperchromic microcytic cells. And this is an example of, with Meredith's heavy. So if she came in complaining of fatigue, one of the things I want to do is ask her about the frequency of her menstrual cycles and how heavy the flow is. I'm serious. If she, maybe I shouldn't pick on you. Maybe I should pick on this person sitting here. You know, if she describes that her normal periods are 10 days long, the normal period is 3 to 5 days. The first part of it, the last part of it is the flow is very minimal. It's the middle, kind of towards the first that's the heaviest, and then it tapers off pretty quick. Okay? but she describes 7 days of heavy flow. You'll get to the point where you'll ask them, how many tampons or pads do you go through, or panty liners do you go through in a day? You know, if she's soaking one every hour, that's pretty serious. If she has a tampon that will last 6 hours, that's not so serious. So you can, a lot of times, clue in on, well, she's a student, so her diet sucks anyway. Plus she has periods 10 days, every 28 days, you're probably dealing with iron deficiency anemia. If I started her on iron, as I said yesterday, and I got a retic count 7 days later, and the retic count does not go up, what am I thinking? It ain't iron deficiency. The next thing on my differential is, well, the other things on my differential are here. Thalassemia, chronic disease, is she eating lead paint? So, thalassemia is something that would be very high, especially if she was of Mediterranean descent. Okay? Asian, not so much. Mediterranean descent, yep, that would be high on my list. I had this huffer one time as a student, talking about lead poisoning. I had this huffer came. Why is it that huffers only use gold paint? You know, I mean, Brad, why is it that you guys huff only gold paint? You know, they come in with this gold paint around their face. It's really impressive. So I stayed up, it was like 1 o'clock in the morning, get to the minute. So I have to stay up and do his admit H&P and the admit orders. It's 4 o'clock before I go back to bed, and I gotta be up in 2 hours for rounds. And by the time I get up to go make rounds, he went AMA. He left AMA, against medical advice. He left, he walked out of the hospital. The very next freaking night, he shows back up, toxic from the gold paint he's been, so I had to do it all over again. Boy, I was pissed. Any other questions about MCV? The normal MCV is about 80 to 100, and so in iron deficiency, you want to see it less than 80. In a macrocytic anemia, like B12 folate, it's going to be up around 120. The MCV will be up around 120. It'll be large cells. MCH is the mean corpuscular hemoglobin. It says here, determines the mean quantity, the weight of hemoglobin in the average RBCs. And it's measured in, since it's weight, it's picograms, actual weight in the average RBCs. Again, Annie got correct in that hyperchromic cells, it's decreased. You're really not going to see hyperchromic cells. I don't think I've ever seen that reported, hyperchromic cells. There are conditions where you have an increase, like in thalassemia, where you have beta thalassemia, which affects the beta globin gene, where you have a decrease in the amount of beta globin, and the cells compensate by increasing the amount of alpha globin. But I don't think that really makes a hyperchromic cell, because I don't think those cells live long enough to really make a difference. So hyperchromic would be the only thing you really, normalchromic or hyperchromic are the two you're going to encounter. Now, the mean corpuscular hemoglobin content or concentration is a little different than MCH. You calculate it different anyway. It determines the amount of hemoglobin to the volume of cells, not per individual cells, but to the cell mass. I don't use the MCHC in, when I look at indices, I look at MCV and MCH. Those two tell me what I need to know. If something goes beyond that, they need to be in the realm of a hematologist, not in my world. Okay, MCV and MCH are the two you're gonna rely on 99.9% of the time. Now, Sarah Hawk, who's gonna be talking to you this week, and Selby this afternoon, they have different ways of looking at lab. But to the general person, to the emergency room person, urgent care, family medicine, MCV and MCH is all you're gonna need. The RDW is the red cell distribution width. It's kind of interesting because it gives you the range of the sizes of RBCs around the mean. And in cases of diseases like anemia, and you really don't understand what's going on, look at that RDW. If you've got a big wide RDW with cells of varying sizes, something's going on there that needs to be investigated. And by needs to be investigated, I'm talking about things like electrophoresis of hemoglobin. I'm talking about bone marrow biopsy, which is, these are not minor things. Okay. Platelets are the last heading here. There's a wide range in platelets. 150 to 400,000 per cubic millimeter. Very wide range. Thrombocytopenia is the reduction below 150. And most of the time, you really don't need to get worried about thrombocytopenia until it starts heading down below 100,000. When it starts heading down below 100,000, you kind of need to keep an eye on it. Bring them back for repeat CBCs to make sure that something's not going on. Make sure they rebound quickly. Let's say you put somebody on amoxicillin and you got a CBC on them for 10 days later because they weren't responding and the platelet count's 80,000. You have to worry about a drug-induced thrombocytopenia, which at times can be severe. So follow them. Stop the amoxicillin and get a CBC the next day. Make sure the platelets are rebounding. I've had patients before where I don't know what caused the thrombocytopenia, but I had them coming in every day, every other day for 2 to 3 weeks, waiting for their platelet count to go back to normal. It eventually did. Why it was abnormal? Don't know. It just was. If it gets around 50,000, you have to worry about when they brush their teeth, they start bleeding. Or if they strain to have a bowel movement, they rupture something back there, they start bleeding. When it gets below 20,000, you better put them in the hospital. You better start transfusing platelets because they are going to bleed. And it's probably not going to stop bleeding once it starts. So 20,000, get them in the hospital. There are tons of causes for a decrease. The drugs, one of the most notorious drugs for thrombocytopenia as a side effect of drug is Motrin or NSAIDs. So you always have to watch out for that. And if a person does become thrombocytopenic because of that, tell them you can't take that anymore, you're allergic to it, you have to rely on aspirin or Tylenol. Stay away from the NSAIDs. ITP, idiopathic thrombocytopenic purpura, is an interesting phenomenon. It's usually due to a cause. It's idiopathic, meaning we don't know what it is. But it's usually due to, let's say, you got an upper respiratory infection, a virus. 2 weeks later, you showed up with these purplish spots on your skin, which represents bleeding, and you have a platelet count of 40,000. ITP is can be your body's reaction to an environmental stimulus like a viral infection, a common viral infection. or you started taking a drug like hydrochlorothiazide, you had a hypertension, patient with hypertension, the first thing you do, put them on 25 milligrams of HCTZ once a day, and 2 days later they show up with all these purple spots. So, ITP, you're going to run into ITP. You need to fix it, you need to watch it. Most of the time, you put them on steroids, they'll rebound pretty quickly. It causes for an increase in platelets. 1/4 of the time, it's because of a malignancy. Always pay attention to an increase in the platelet count. There are a couple of other cases here. Polycythemia vera is a condition you need to Google. It's sort of the opposite of ITP. And splenectomy will cause an transient increase until you normalize. The mean platelet volume is the platelet indice that was on that early CBC that I showed you. I don't know, I never paid attention to the MPV, ever. What its value is in hematology, I don't even know. But it's usually reported. Okay. Any questions about CBC?
Yeah. So on the results you had there was anisocytosis. And the red blood cell distribution was within normal. Is it only looking at the normal mature red blood cells, or how is that explained?
Right. So the question is, how is it anisocytosis if the RDW was normal?
Yeah.
It's the characters of the cell. If you look at them, what I didn't go into was there are a ton of different characteristics of RBCs. I mentioned yesterday Cabot rings and Howard Jolly bodies. When you look at RBCs, there are things called spherocytes, or there are probably at least 10 different characteristics of RBCs that relate to disease or even normal findings. If they're present, they're going to report them as anisocytosis. Anisocytosis doesn't necessarily mean they're not all the same size, they're not all the same character. So that's how an RDW would be the same. Like sickle cell disease would be reported as anisocytosis. They don't look the same. Interesting. What the problem with sickle cell disease is you have these malformed sickle-shaped cells that they get stuck in capillary beds, and you wind up with ischemia, particularly of joints. And that's the pain of sickle cell. Every sickler I know is unfortunately, an opioid addict, because they have to go in so much, and the treatment, of course, is you give them opioids, and they become addicted to them. It's horrible. It's a horrible condition. Interestingly, a deer, venison, a deer, all of their cells are sickly. Or sickle. Why they don't have sickle cell, I don't know. Why they don't clog their capillaries. You mentioned thalassemia and anisocytosis, target cells. If I say target cells to you, the answer is thalassemia. And it looks like a target because you've got there's red outside, a clear middle, and a red center. RBCs look like targets. So, okay. Anything else? Okay, have fun.